such as complex case management and how are we working analytics to improve healthcare. So it really fits in with our charge all along. We will continue to work with value-based contracting. Many of you know that also was identified 3 years ago. We were in the very early stages of that. We did bring in a national consultant. Today we have some contracts around autism and around assertive community treatment that have a value-based contracting component and an alternative funding component attached to it. We also are going to continue to focus on provider network development and implementation. And I like to remind people that with some of the changes at the federal level, there has been greater emphasis on the role of the state as well as the PIHPs, prepaid inpatient health plans, to really be very involved with the provider network to make sure that there's appropriate capacity to provide services, to make sure that there's consistency in the delivery of services, to take a hard look at consistent funding and outcomes that are achieved. So we have had an increasing involvement with the provider network. Many of you know that we've started to do direct contracting with many of the direct providers. This last year, we're working directly and contracting directly with vocational and non-vocational providers. And we expect by the end of the year to have contracts with residential providers. Next year, we're likely to take a hard look, or we expect to take a look at the contract with what the core provider organizations in terms of expectations and looking at service models, funding, and incentivized payments for outcomes. Next area is advocacy and empowerment. I like this area. It's the one that energizes me because I always say it keeps us involved in the fray, if you will, of making sure that we have good laws, good funding for people, but it also certainly includes people directly in their own services and how they affect us and influences a system to be more responsive to them. We have community education, and again, that's part of making sure that the community understands who we are as a public mental health system and that we're responsive to people's needs. It will continue to look at the anti-stigma initiative that we do. It keeps us involved with our community partners around some of the suicide prevention activities that we're doing, especially for youth. And it keeps us involved in advocacy campaigns. I think many of you know that, or I believe anyway, that we have a strong advocacy group here in Oakland County. And I have to tell you, if you don't know already, it's my belief that Oakland County really helps sets the pace across the state. We seem to be able to identify early on some of the major issues and actually put together talking points and take action around that. And I know that that is something that people we support, families and providers and others in the community have asked, that we have talking points that we speak with a consistent voice from Oakland County on behalf of the people served. Peer supports and services continue to be important. How could we not have that in the strategic plan? Over the course of plan development, whether it's the strategic plan or annual plan, we've seen us go from peer specialists to peer mentors to family guides to youth guides. We have recovery coaches through substance use disorder prevention planning. And this year, as part of the annual planning, we're having people trained to be health guides or health mentors, and that is really exciting. So we're going to continue to work to build that out in areas that are needed, but also to increase the number of people available. I can't tell you enough, or you probably can't tell me enough, the importance of the lived experience. And you know, it always hones the work that we do and reminds me that sometimes when we sit in an organization, we think we know what's best for people, but when we really listen to their life experiences, we know that we're fairly close, but we have some tinkering to do. So Peer supports, the involvement of people continues to be front and center. Person-centered planning, family-centered planning has been in our radar for quite some time. We hear from people that it needs course correction. We started some initiatives here, I must say. We backed off just a little bit because we heard that the state was going to take the lead. We want to work with the state. We're not quite sure what that's going to look like yet, but we will continue to focus on improvements in that area, as well as self-determination and the use of independent facilitation. And finally, in this area, we want to keep our focus on choices of services and providers for people. We know that we have an increasingly expansive provider directory. We know that we want to post some videos that we recently developed so that people understand more about the services that are provided in Oakland County and the choices that people have. So we have some other initiatives in mind, and that will be developed and covered in that area. The next area is budget and finance, and we know that we will continue to work on developing a balanced budget, and that includes not just what we initiate here, but it takes a village, it takes the network, it takes people who are served to really work together to make sure that we access as many natural community supports as possible, that people bring their resources to the table, that if they're eligible for Medicaid, that they get their applications in and keep their applications current, that families work in that area on their behalf, that we collaborate and coordinate across not only public systems, but with the private sector on making sure that people have equal access to things like the local recreation centers in their communities, and that they really use their community resources as much as possible. Funding strategy will continue to focus on alternative funding approaches, and I know that we're almost toward the end. We have worked with a number of service populations, and I think it's important for people to know that that sounds scary. It's a very different change for a lot of people in terms of alternative funding and funding for outcomes and adding incentives, payments for outcomes. It is a national trend. Everything is headed in that direction. We're working very hard to understand how to do that with input from the provider network and others involved. And when we get feedback that things do need to be changed, we certainly hear that and have been making some adjustments along the way. Provider funding really focuses on direct care staff, really when I think first and foremost, making sure that we have any funding that we can figure out how to capture gets moved in that direction. I was just reading something in a national newsletter recently about this turnover rate in direct care staff, so I want people to hear that we recognize that that's an issue, and we'll continue to focus on that and advocate together for continued funding and increases in that area. But I might also say that at this point in time, again, it's not just direct staff, because we are seeing a lot of professional staff who are starting to move in other directions, and we want to make sure that we have competitive salaries in that area. And then finally in this area, this is Anya Eliason, our Chief Financial Officer, talked to me about this, and we added this. I think everybody knows that we have to continue to advocate for appropriate funding for the system. At the same time, we want to make sure that there's an equitable approach across the state in terms of a funding formula. So yes, we advocate for Oakland County. That is extremely important to us, but we have said for many years now that it's important that there's consistency across the state and people have equal access and appropriate funding across the state. This concept of pitting one part of the state against the other, if you've been a winner this year on the funding formula or a loser this year, is really not where we want to be in our conversation. Sometimes it may be the reality, but we have to first and foremost advocate for appropriate funding for the system. And I think many of us know that over the course of years, we've seen a large amount of dollar moved from our system into other arenas. Next area, not surprisingly, continues to be healthcare and wellness. Again, 298 is all about the integrated healthcare approach, Section 298, and I think it's important for people to know that we do a lot of work in healthcare and that we're working very hard to be able to move data and information across systems. And when people talk about integrated healthcare, a lot of times people like to stop with the funding, get the funding in one bucket, and will automatically have integrated healthcare. Well, we believe that it starts with people served, and in order to serve people well across the system, whether it's with their primary care physician at an FQHC or at their own primary physician community, we really need to be able to share information. So we have been advocating with the state, for the state, that they really step it up and work the technologies so that we can share more information across systems and provide better care for people, not only at the individual level, but really when we look at the aggregate information and the trending, how do we then figure out where to go in the future to support people and their health care? We're going to take a hard look at what's happening at emergency departments and for hospitalization for people. This area talks about a report. I mentioned it's called the Michigan Inpatient Psychiatric Admissions Discussion. If you hear people use the acronym MIPAD, that's what they're talking about. And it's a fairly lengthy report, but I highlighted a few areas where we look at standardizing pre-screening processes across systems, sharing, again, information across systems, and then talking about telehealth. How do we use the technologies across systems to improve care for people, to shrink the time that people may be staying in emergency rooms or emergency departments, so that they either, return home and get the care they need, or if there's a need for hospitalization, that they get the certification, dispensation, and the timeline for them to actually get to a hospital and get the treatment they need is improved. And then the final area is population health management. Again, that's the nod to the data analytics at the individual level and at the trending level, and how to really actually ultimately where we want to get is to be able to look at data and do, I'm going to miss the phrase here, predictive analytics, so that we can really, again, plan for the future, so that we know the trending and we can develop services and supports and certainly the financing around that. This area is chock full of topics, but it certainly is important. This is where we see children, youth, and families. And again, I talked a bit about looking at the things we need to do to support families, keep them together. There's evidence-based practices for children, youth, and families. I had previously talked about the suicide prevention initiatives. There's peer supports, mental health awareness. With the schools, we have collaboratives with the schools. So this is where this fits. And when it comes time to develop the annual plan, you'll see probably in this area an expansion of goals and some objectives that we're working on. The same thing with criminal justice. I talked about diversion activities, keeping people from being reincarcerated, or recidivism is the terminology that's used. How do we work to make sure people get, with mental health concerns, substance use concerns, get good services while they're in the jails? And we do have a strong initiative with the Oakland County jail system, and that will continue. Crisis services, again, remain important. We do have an initiative we're working on now in a mobile crisis unit for youth, and that is a department expectation. And you'll see that moving into the development and implementation by the end of the year and into the next fiscal year starting October 1st. We do have a cultural competency plan, and that really is to look at disparity of services. This plan is a multi-year plan. It's 5 or 6 years, so I think we're into the second or third year of it, but it's taking a hard look at our data. I always say we need to know who's coming to us for services. Is it representative of our Oakland community? And even once inside our public mental health system, do people have truly equal access to all the services and supports? Or are we doing some things unconsciously that are moving people in certain directions so that we find ourselves delivering services in an unequal fashion? So I look forward to working more with our community partners, our provider partners as well as our community partners. Social determinants of health. Some of you may have heard that phrase bantied around. I shouldn't say bantied because it's becoming a pretty prevalent statement in the work that we do. It really involves those factors that influence people's health. It really is more about where were you born, where did you grow up, what kind of income did your family have, where do you live, what's your housing look like, and they all affect people's health. And so we want to make sure that we focus on housing, employment, and transportation, and all three of those show up as factors in social determinants of health. If you don't have transportation to get a job, your income isn't where it needs to be to get you to the health care you need, to pay for the health care you need. If your housing is such that you don't have heat or water, your health may be involved. And it's not true for everybody, but I think many of you know that people who come to us for services and supports, quite frankly, live in poverty. I'm going to be very honest about this. So it is a poverty issue. It's a disparity issue that we have to own and pay attention to, and then do something about it with the information that we find. And finally, in this area is substance use prevention and treatment. We had the team, if you will, in the services and supports come to this organization almost 4 years ago, or maybe it's over 4 years ago, And so we've really seen an education with the work that we've done. I certainly can speak from where I sit that I thought I knew some things, and then comes the work and the services and the coding and the funding and the new initiatives, and then I learn how much I don't know. And I know that we've worked very hard to improve the integration of substance use with this organization, and I'm very pleased with where we are. We're not at the end of it. I know there was a discussion that it probably would take about 5 years, and it's probably going to take about 5 years for us to really get us where we need to be. And if there are any substance use providers watching, I know that you're working with our new electronic health record. And I will say to you, just stick with it. I know that we'll get some good information out of that and improve it. So I appreciate you in the work that you're doing with that. Finally, the last goal area has to do with technology and innovation. And let me tell you, we've had some very exciting conversations around this. I think many of you know that this organization has launched the use of dashboards many years ago, and if you don't know what that means, it's basically a way of using our technology, our computers, to look at data at the same time our provider network is. So over the years, we've identified what data is needed, what fields are the fields of truth to get to the information we want. So we identify that. We hopefully we'll develop more of a data dictionary for everybody to look at so people know what we're looking at. But we probably have about 100 dashboards, maybe more than that by now. But we look at that in terms of utilization management, trending of revenue, and we'll continue to do that on behalf of people. Individually, we can drill down, but also to take a look at where we are trending. Innovative technology is probably the area where we're going to see changes not only in the work that we do, but across the entire healthcare industry. And Many of you know that we have an app that's called My Strength. Some of you have downloaded that and are using that. And we've seen that whole industry expand exponentially. And so we have a lot of different apps that we have access to. We have wearables now. I don't know who's wearing a Fitbit today, but that gives you a lot of personal information. We're seeing a lot of that tied directly to doctors' offices now, whether it's tracking work with people who have diabetes or any other health conditions. So we'll see a pickup on that. We'll also see interesting things happen with smart speakers. Many of you have Alexa or Google Home or in any one of those smart speakers in your home, and they're really great for telling you what the weather is, but we're seeing it being used and programmed in ways that tell people what their day might look like when they should take their medication, reinforce them when they take their medication. So we're going to work with the provider network to pilot some of these and infuse them in our system. I think it's also interesting to know that there are some evidence-based practices where you can get a program loaded on your computer or smartphone, and it like cognitive behavioral therapy already is something that you can interact with a program, and it is done in conjunction with working with a therapist directly. So we're going to start looking at this, and telehealth will take more of a front and center in the work that we do. And then finally, a health information technology or a health information exchange is really, again, figuring out how to develop a system that moves the data and information across the physical health system and the behavioral health system and really any other health system that we interact with. I like to tell people here that if you read in the paper about some of the disruptors, as they call it in our system, and technology is one of those new disruptors because it's exploding in different ways it can be used. But a lot of these mergers and acquisitions that are happening in business are things we need to look at. Aetna and CVS has had a big merger. Many of you know that you can walk into CVS or any Walgreens or any of those drugstores and you can get flu shots and vaccinations, and we expect to see with some of these mergers that some of these local pharmacies will become more clinics. Some of them may even be built out to be minor urgent clinics, so it's going to change the landscape of what healthcare looks like, and really we have to pay attention to it because we're never quite sure what our touch points might look like. If they do telehealth at a local CVS, can they then connect with us? And is there even at that point in time in the future some kind of screening that could potentially be done? And it may sound very, very futuristic, but these things are moving very quickly now, and it becomes important for all of us to follow that landscape. So that ends or concludes my discussion. I do want to let you know that on the website, if you look at the strategic plan, it has a an email site where you can provide directly input regarding this particular plan. So what I'd like to do right now is ask the audience if there are any questions or comments about the plan. This is an opportunity for feedback, and I certainly welcome it. We all do. Everybody loved it, I can tell. All right, if there are no questions, then I believe that this concludes the presentation. Thank you so much for joining us today, whether you're with me face-to-face or you're watching via other avenues. We really appreciate who you are, your interest in the work that we do, and again, I can only tell you that your feedback is extremely important to us. So please, everybody individually or collectively, I happen to know there are some clubhouses out there who watch this as a group, so I give you a shout out to a couple of those. I visited you, but please know that your group work or individual feedback is really important to us. So I look forward to hearing from you, and thank you very much.